Good evening, everybody, and welcome to the speaker series tonight. It's incredibly important, the speaker that we have tonight, Dr. Paul Parks. I'm not sure about how to introduce him because he just literally apparently came in from his shift at emergency. So if you look at his face, it's remarkable what doctors put up with, and they can still be standing and looking so calm. Anyways, Dr. Parks probably doesn't need any introduction. He was the recent president of the Alberta Medical Association, and to get to that position, one has to achieve a lot of knowledge and respect from the community and have worked in a wide range of capacity regarding his training as a physician. So I'm going to read the land acknowledgement now, but I just want to say that we have people all across Alberta, so it's not specific to Treaty 7 tonight. We are grateful for and respectful of the traditional knowledge keepers and elders who have gone before and those who are still with us today. We recognize the land as an act of reconciliation and that we are here as visitors, and we have gratitude to those whose territory we live in and work and recreate on. And with that, I will hand you over to Dr. Paul Parks. There will be room for questions afterwards. So when you have a question and you think of something, please jot it down and then you'll have your moment to speak. Welcome and thank you again so much, Dr. Parks, for being here to help us understand what's a very confusing and to many of us frightening time in healthcare.
Well, thanks very much for having me. And yeah, so as noted, I mean, I'm just in case people don't know, I'm an emerge physician. I've trained and have been in Alberta since 2000. I've worked in major academic centers up in Edmonton. I've been down in Medicine Hat since 2009. I did just come back from a shift today, even a busy shift in the emerge in Medicine Hat. I am the past president of the AMA, and I've been the president of the section of emergency medicine in the AMA for a long time as well, off and on, and not currently. But I just should state that I'm kind of just giving you my own personal perspective and reflections and my own opinions here. So I'm not representing specifically the AMA or the org. I'm sure that a lot of my colleagues share a lot of my concerns. I'm positive of that, in fact, but I'm just speaking, giving you some of my own, based on 25 odd years of experience, but what's been happening in the last couple of years specifically, and just kind of knowing firsthand, seeing the cracks and the chaos and actually, working a difficult system, the courage that the healthcare workers are trying to do to keep the system going. So I could talk on this for a long time. The healthcare is complex, so I don't want to go on and on. So I'll kind of hopefully kind of touch on some key topics, and then, like I said, leave some time to answer questions and maybe bridge out on some things a bit. But some of the key pieces just to take home that I'd like for everyone to know is there's a couple pieces. One, in healthcare in general, why every Albertan should care right now is we're in danger of losing the voice of our experts and our healthcare workers and the people from the front lines. That's one. Another is right now there's active disintegration going on in our healthcare system. And I use the word disintegration in a very specific way, in the sense of it definitely is disintegrating an integrated system, but it's also disintegration, like we know of, leaving very little left and destruction and chaos, kind of. So I'm going to touch on that a bit. I'm going to talk a bit about on political interference and why government involvement in a complex system like healthcare, and what's going on a bit with corrupt care and some of the issues, and why all Albertans should care about that and actually know about it a little bit. And then a little bit about where there's dangers of we're moving towards, two-tiered at a minimum, if not private, and a system that will be really inequitable. And it's something we should be aware of. And then the last is just to kind of put out a plea to thank you guys that everybody's here, thank all the people here. But I think our healthcare system, is going to need an activated and mobilized public to actually. It's a bit weird, across the province. I was talking with Ali about everybody across Alberta, affordability and healthcare are number one, two priorities for everybody. There's a couple others that go in there, but they move around. But it's knowing that those two things are really important, and how interconnected your health can be with your finances and your affordability of living. It's weird how people might not really understand what's going on with our system, even though it's one of the most important things for them. And so just kind of reinforcing what groups like this are doing, saying we need to get the word out in different ways and make people understand what's going on. So hopefully I'll touch on those, and hopefully this will be interesting. And so I think one of the big key pieces I think that's really important to touch on around is we're really in danger of losing the voice of experts, and we have a bit of a cult right now where the expert voice is not respected. But even now, it's getting to the point where it's actively being suppressed to a degree. So healthcare workers now, we're in a state where there's active fear about speaking out. There's active fear about advocating for patients of the system. Really good healthcare leaders and frontline healthcare workers, whether they're in administrative positions or just frontline trying to advocate for the system and patients, are being muzzled. They're quite afraid to speak out, because again and again they're seeing now this government is quite draconian in regards to, if people are sending messages that they don't like, they have we're seeing again and again a repeated pattern of where they are either outright firing people, or they're moving them in the organization, and as soon as they get moved, all of a sudden there's no job for them now. So they've just been let go, and they blame it on reorganization. And what's really critical in a province like Alberta, where we've had a single healthcare system and we only have one healthcare authority, is if you lose your job in this province, you don't work anywhere else in this province. If you're a healthcare administrator, if you're a nurse, if you're a physician, if you can't work in, if say I really upset the premier who happens to be down in Medicine Hat, Alberta, and I get fired and can't work in Medicine Hat, it's not like I can go to Calgary. It's not like I can go to Edmonton. It's the same health authority, same people would be hiring. It's a little bit easier and safer for physicians, maybe, but if you think about it, a lot of these really good administrators who have been in positions and worked up and have really you know accrued a lot of knowledge and a lot of experience and a lot of expertise, they are really in an environment where if they lost their job, they might not ever get employed again, but they'd have to leave the province for sure. So that active muzzling is a really big issue. So an example I can give you, just concrete, so everyone can know it. So look at our public health right now. Our public health, we don't have a chief medical officer of health. We haven't for a long time. We had an acting chief medical officer of health who was actively muzzled, who couldn't do, and the government might quibble around the words like muzzling and not allowing them to speak and advocate. But here's the scenario: is the chief medical officer of health, previously all the comms were written by Alberta Health and the Premier's office. They couldn't do anything. They couldn't be out there publicly advocating. They couldn't communicate in anything in public health related without it being written and buffed by the Premier's office, even at that level. And so you see, we haven't had a chief medical officer of health out in Alberta for the last 2 years actively talking about what's going on. Now we have the worst measles outbreak in over a half of a century. And I can tell you, I saw memos. I'm very aware of April last year. Our acting chief medical health was telling our government this is coming, that we should prepare and we should do advocacy around this. And our government chose not to. So now what does that lead to is, not only did they choose not to act on the advice of the experts, but they also muzzled the experts from being able to go out and advocate and do what their role would be in public health. And public health is a perfect example of, you need to educate the masses around and Albertans, and you have to educate people why public health is important. Why are all these preventative measures really important before an outbreak happens, and why an ounce of prevention is worth a pound of cure. You need a really active campaign and education. You have to meet people where they're at. You have to build trust. and all those things have been eroded. And so now we're in a position where we can't recruit into Alberta. Nobody, worth there, anybody that would have the credentials and the expertise and want to be a leading public health expert in Canada would not want to come into this environment right now, because in a nutshell, they would literally be getting all the blame and all the negative and everything that bad that's happening without any ability to really influence direction and or to actually kind of take action and lead. And that's just been building. And I just use the public health and measles as an example of that's what's happening in all aspects of our healthcare system right now. I'm going to touch on restructuring, but if anybody comes along and tries to say, listen, I don't think this plan's working because A, B, or C, there's a reactionary actions that happen where those people lose their jobs, and it's chilling, and it has to stop. It's not good for anybody in Alberta to have lost that ability for our healthcare workers and our healthcare experts to speak truth to power. And sadly, even now, we even have an environment where that's actively happening, and then our premier and government are actively courting what they call contrarians, and they're bringing out a voice that is not necessarily expertise and is not necessarily informed. And so it just puts us in a really, really difficult position. Same thing that's happening right now, for example, with the restructuring. It's been going on for a couple of years now, and the muzzling is even more grim there, because with the reorg and where people are not sure if they're going to have jobs, and they may be very skilled in different, so cancer care, surgical care, name all the different facets of our healthcare system that's really complex, and they're not saying a peep right now, because there's a fear that if they put their head up, it's like whack-a-mole. If they put their head up, they're gone. And someone that is a yes man or a yes person, or someone that is not going to speak truth to power, just gets elevated, and the people who have the knowledge and expertise don't. And that is really, again, I'll just stress, it's so important to understand that that's really bad in the big scheme. But think about 2 years of restructuring and not having any of our healthcare leaders speak up and say, listen, this paralysis and chaos and the decisions you're making, the things you're doing are making the system worse and making the outcomes for patients worse. So that'll lead into this disintegration of the public system. Is that, like I said, it was in November 2023 that the premier and minister announced they're restructuring. They're going to create these four orgs. Now we have these silos, so these four silos, and right away from the get-go, I was at the table when this was announced as the president of the AMA, and my very frank feedback immediately saying was, well, like, how are you going to integrate these silos? How are you going to make sure that the patient experience and the healthcare workers and the whole system works together? And they said, don't worry about that. We'll figure it out once we get the structure in place. And now here we are, almost, a year, 18 months, call it. And we're still working on the structure, and we're still announcing more silos, and we're doing more of this fragmentation as we go forward and forward, to the point now where a couple big pieces, like I said, I could talk about all these issues for a long time, and so I don't want it to be a droning on and lecturing, but like a key couple pieces of this is now here we have four administrations, four ministries, four organizations, now four bureaucratic administrations. They're all independent. They all have their own focuses, and the government never thought through how they were even going to fund and create those structures. So where did they get the money to create our bureaucracies? Is they've been taking it from frontline care. They've actually been cutting frontline care, things like access to, funding for cancer care. I mean, the popsicles popsicles for pediatric cancer patients, like that's just it baffles me a little bit that hasn't resonated more for a lot of Albertans. I think it did. I think they got it, but for them to understand that that's just like, it's the perfect encapsulation of what's happening now, as the administrators are told to save literally hundreds of millions of dollars in clinical care, so that they can fund these bureaucracies, these administration structures. And so they're literally taking frontline money and frontline care to create these four redundant bureaucracies. And then on top of it now, you have this idea of where they want to try to uh, foster competition and foster this is at a lower level when they're talking about hospitals, where the premier now comes and announces that they want to try to have local decision making, which I'll come to in a bit. But what happens and what's lost in all of this restructuring, that I'll just reiterate again and again, is there's no integration, there's no operational control. So if I were to just give you one example that would really highlight that, we told them right away, and we told the consultants. So our government now, instead of talking to physicians and the healthcare leaders they have in the system, they're spending $1 million a day to go to consultants who then come to us and say, "Hey, what's going on in the system? What's the issue of these new org and these new four silos, for example?" And so one example I'll say is, if you think about when people get admitted to hospital and are elderly and frail, and they may not be able to go safely back to independent living. That's a common thing that happens. And so once their acute care is taken care of in the hospital, they get designated as alternative level of care. And all that means is they could go home, but they need to go home with either some supports, whether it's home care, or maybe they need to go to supported living, or maybe they need to go to long-term care, and that's common, and that's a big piece of our healthcare system. And right now in our hospitals across the province, about 35% of all of our beds in our hospitals are what would be patients, and they're not just seniors, because they could be people with complex mental health. There's a whole bunch of reasons, but these are people that are stranded in our hospitals, stuck in our hospitals, because there's no existing infrastructure and continuing care for them to go to, or it's not adequate, or it's not properly funded in terms of the supports they need, or whatever the reasons are. They can't go out of the acute care hospitals into the continuing care. Well, now we have two different silos with two different ministers, and now we have why would I'm simplifying this because I would hope they would care, but why would the Minister of Continuing Care want to spend a whole bunch of effort to try to pull those 35% out of the acute care, so that it's more work for his org and more work for continuing care, and costs more, and it's a lot more headache for them when they're stuck in acute care and their acute care's problem? And that just highlights that there's no ability to coordinate or even talk about what's going on between these orgs, and there's no operational control over this. There's no one above these orgs saying, "Oh yeah, it's mission critical that we make sure this flow happens so that patient care can be taken care of." And to just really simplify, why would Albertans care about that if they're not stuck and stranded in these facilities? Is because that's why we have emerge overcrowding. To really simplify, why are you waiting 10, 15, 16 hours? Why are you spending 5, 6 days admitted in a busy, loud emergency department when you're sick and admitted and you can't go up into the hospital? Is because we have these patients stranded in our acute care hospitals that can't go out to continuing care. And we've known this for 25 years, but probably longer. And the fix is complex. I'm not saying it's easy, but with the current disintegration and siloing and no operational control that's been created by our government, it's even worse. It's infinitely worse. And what I'll just stress is that there's no plan. There is no, all of a sudden the premier comes out and announces and does a nice flashy 5-minute video around how we're going to have local decision making. Like, I want to be really clear. Local decision making is an excellent idea. It's something that if you went across the province, a lot of healthcare workers were saying that is something that we needed to improve on, is being able to have some local decision making. But it can't happen in a vacuum. It can't happen in a system that's disintegrated and not coordinated. And no one would have ever said completely blow up AHS, create this weird, bizarre Frankenstein type model, and then give us local control on top of it, because there's no plan and there's no roadmap. There is no consultant. There's no healthcare expert out there right now that can show you, or anybody in the healthcare system, what the premier's roadmap is for this change management and this plan to restructure our most complex. Probably it's one of the largest healthcare organizations in the world, and easily our most complex public service in Alberta, most expensive too. We spend the most amount of money on it, and government's just changing it piecemeal with no plan, with no organizational change management. And so we just need to start talking about this and saying, listen, we're going to spend billions of dollars on our healthcare system, and it's a top priority for Albertans. Show us the plan. The government should be saying, well, here's why we're doing this. Here's the roadmap. Here's what's going to happen. And that'd be great for Albertans. It'd be great for us working in the healthcare system too, because now it truly looks like we have no operational control, and we're not moving in a direction where things are moving in a positive way. They just keep getting worse and worse and worse. And so, and then if you want me to go into even more depth on some of this, you'll see that their intention now is with this chartered surgical facilities, which I'm going to touch on quickly, and hospitals maybe being sold off and or privatized or delivered by other organizations. Their intention is within each org, within the acute care org, for example, to have hundreds of clinical service providers, they call them. So chartered surgical facilities, hospitals, maybe it's urgent care centers, you name it, and they're all going to be doing their own thing, and they're all going to be looking after their own little piece of the puzzle, with no operational control over top of it. And so, as one easy example that anybody can think and understand right now, there's nobody coordinating workforce in our province right now. So if you have a finite workforce and they can choose where they're going to work and where they're going to go, and you create 100 different options that people can work in an acute care org, for example, and it's the wild wild west, and they can go where the work's the easiest and the pay is the best, and nobody ends up working in our hospitals. That's the roadmap. That's the path we're on right now. And we are really worried that if we don't, get to a point where we kind of put the brakes on this a bit and say, hey, listen, what is the plan? Then we might, hit a point of no return where there aren't physicians working in our hospitals. It might just be emerge docs and ICU docs, and everybody else has fled the hospitals, and that'll be devastating for our healthcare system, and it will take years and years to get back. And as much as we try to advocate and try to tell the government, they're not listening. I mean, one quote told anonymously to me by a senior consultant is that, nobody in the government right now has, nobody in consulting government, anybody has courage, experience, or vision to develop a whole system roadmap, because the premier believes that integration doesn't work. So nobody is allowed to create a roadmap that shows that integration is needed. And so the consultants are taking lots of money, working on plans that they know may not even work, because they know, as a backbone of a complex system, integration and operational control would be a critical top level must have. But they've been pretty much told they can't have it. So that rolls us into, and I'll be a bit quicker on here because I'm not sure on our time, but around this, the political interference and the corrupt care and what's happening with CSFs, is that a lot of what I just said leads into why people should really pay attention and care about what's happening in corrupt care, and why the concerns from the previous CEO around CSFs, as one example. So again, I'll just say these are allegations. Of some of this needs to be borne out in court. Some of this I know is factual, but again, it's just the key pieces that are really important to understand is that the government is making backroom side deals with different providers, and they're going around things like procurement processes that are part of a process that governments have to do to ensure that the T's are crossed and the I's are dotted and everything seems legit. And they basically are undermining those processes, going around them. And then now we're entering into a scenario where, so allegations around, are we paying too much, and are there some specific people that are really influential in this? This needs to be borne out in court. We need a public inquiry. We need to get a light on all of these things so we understand what's going on. But what I can tell you factually around our healthcare system is And I mentioned workforce wise, we do not have enough anesthetists, anesthesiologists. We do not have enough nurses. So if you have a scenario now where you can create simplifying what's happening in these chartered surgical facilities is right now, most of them are doing, eye surgeries and bone surgeries, joint surgeries, and they're taking the easiest cases because those are the only cases they can do. And they're doing them 9 to 5-ish, Monday to Friday in a very controlled environment. Well, anybody on here can decide and really quickly figure out where are anesthesiologists going to go work. If they have the options to go work 9 to 5, Monday to Friday in a wonderfully controlled environment, versus say having to be up at 3 in the morning to take care of that car motor vehicle collision that has 5 near dead people, that is totally chaotic, that is very difficult at 3 in the morning, and have to do that day in and day out and be on call and deal with the harder cases. So even if you want to compare apples to apples, and they're just doing bone surgeries and cases in the hospitals versus in the CSS. In the hospitals, these are people with very complicated medical conditions and respiratory. They're much more difficult for anesthesia, you name it. The in a nutshell, though, everybody on here can understand that if you make the same amount of money and your quality of life is better and your job is easier and you're in demand, you're going to. It's not like they're giving up on the healthcare system. It just becomes too easy to not go over and work in that. So I'm not criticizing my anesthesia colleagues. I mean, you know what? I'll even give you a clearer example right now of what our government's going to do. They've announced 7 or 8 urgent care centers that they want to have out for private, for profit, private controlled. And I've been the most vocal saying, listen, right now, if you did that, we don't have enough emerge physicians to work in all of our big emerge departments in all of the province right now. And if you create these urgent care centers where they can take care of still sick people, but they're not near as complicated as in the emerge department, they can work, maybe they only work from 7 in the morning till midnight. They don't have to work the night shifts. And you create an environment where it's much more attractive to go work in there. Then you might see physicians like myself and physicians and the nurses, the good nurses, and deciding that over time slowly I'd rather work at the urgent care center than in our emergency departments. And that's not critical of the people making those choices, but if our government is interfering and creating this environment, without having a strategic plan around how the whole system works, then we can all guess how it's going to play out. We all know what's going to ultimately happen. And the thing that I just want to stress is we don't have the workforce for both, and everybody knows it, and the government knows it. Second is if it can kill you, it can't be done in a chartered surgical facility. So do we really want to slide to an environment where our hospitals are no longer functional and we no longer can do the urgency care, urgent care, but we're really, really good at all of the easier necessary care? People still need their joints done, their eyes fixed, and necessary care, but we're creating an environment where if it will kill you, you might end up dying because we don't have the ability to care for you in our hospitals. And some might say this is hyperbole, but we already have in the city. The last point I'll just say as an example, in Calgary, our largest centers in our hospitals, we have a thing called diversion, where if you have an appendicitis or your gallbladder is so inflamed you need surgery, or you have a bowel injury, you could maybe be at the foothills and they don't have a team to do your surgery, and one of my colleagues will have to call an ambulance and move you from the foothills emerge to say the Peter Lougheed emerge, and go to the OR there, because we don't have enough teams in our hospitals in Calgary already, how it exists. Another would be in Medicine Hat Lethbridge. We have empty ORs in our hospitals that we could, have put adequate manpower in there, staff it, and we could do more surgeries. But if they create CSFs and chartered surgical facilities in the South Zone, you're going to drive people out of the hospital, and we'll have difficulty doing our really acute, difficult care. And then that just leaves the next piece now, where we already have in our chartered surgical facilities, many of these are doing for pay already in these facilities. So they are doing out of province is common. They're doing WCB, so they're doing some of these ones that are not in the publicly funded system. But now, even some of them, with our taxpayers supporting the construction and building and our staffing, we even know that there's Albertans paying for surgeries in our Alberta chartered surgical facilities already. So now we're seeing a pattern where if you have adequate resources, you can go get your MRI and pay for it and skip the queue by a whole bunch, by months, if not years. And then you can go to a private facility and you can get your surgery in a matter of weeks instead of a matter of, months to years. If just by your ability to pay solely because you have resources and other people don't, that already exists in Alberta. And as we go on this trajectory of adding the profit factor into these chartered surgical facilities, which they all have, and which government didn't learn around Dynalife. Dynalife is the perfect example of where when you take a core fundamental piece of the healthcare system and try to add profit to it, it collapses. Why did it? I could give you a whole talk about that, but why did it collapse? Because in order to make profit, Dynalife started trying to say, listen, we can't do these difficult tests because they're too expensive, or we're going to take 3 days to do your ECG, your heart tracing, because we don't want to do it at after hours or when we have to have staff that'll cost us more money. And they were trying to make a profit margin on something that is just fundamentally essential to the healthcare system. That adding the profit margin to it just made it collapse unless you started charging the public for it, right? Which is the next step. So, and then I'll just close. I hope that I want to leave time to talk and time for questions, but I'll just say that the reason I'm here, I'm giving you my own personal perspective. I could talk on all those things that I just touched on for an hour or two each, even. They're very complex. There's a lot of pieces to it, but I just think that a big piece now is we have to kind of spread the word and get as many people as we can, start telling our neighbors, start telling people, because it's like that. You don't know what you got till it's gone. People don't actually know what's going on in healthcare until they try to access it. And then every day on the front lines, that this is my experience and my colleagues at the morale, we're burning out. It's really tough to be on the front lines because again, in and out, you're seeing so many people who are coming in need and we can't deliver safe and timely care like we know we should be able to. But in addition, their frustration is very high because it's now, for some reason, they're often quite shocked to learn that you're going to wait 10, 12 hours to be seen by myself as an emerge doc, for example. And then you might spend 3, 4 days in a hallway in our emerge, and then you might go to a hallway up in our hospital, or you might be jammed in a room that was meant for two people that now has four, or you might be put in what used to be a closet. And then as people are going in there and they see their loved ones in that experience, they're shocked and they're like, "What the heck's happened to our healthcare system?" So I'll just close by saying that's why I'm volunteering to be here to give my opinion and my perspective and just highlight some of the healthcare issues so that you all can help, which I know you all are active in trying, but we just need to kind of mobilize and spread the word more. And I think a couple of the things we could really do is start being more vocal. I think a public inquiry around the CSFs is critical because it would really highlight some of all the pieces that we just talked about, that they're doing the reviews in such a fragmented, they're intentionally trying to make it so that nobody will actually see the big picture. So without getting some of these key pieces in a big concerted, big picture way, people might not understand why the CSF is like and I should close by saying there is nothing wrong innately with chartered surgical facilities. They may work in a coordinated, workforce planned, systemic type way, but the way that the government is trying to do it right now, it's actually making care worse for more Albertans than not. So that's a perfect example why a public inquiry would be useful. So I like I said, I could talk lots and longer, so I'll leave it there for now. And I hope that this was informative and happy to take some questions.
Thank you so much, Dr. Parks. If everybody would like to just put their hand up if they want to ask a question, and then I'll call out your name.
Thanks so very much for this presentation, obviously, and you've been direct and you've been hard hitting and you've been honest. So that's hugely appreciated. The mantra that seems to run through your presentation, and unfortunately, Ali has hosted as she has mentioned, many on a collection of different fronts, has always been the same one. That is the idea of losing the voices of experts. And whether it's energy, environment, pensions, whatever the situation might be, we hear that time and time again. Any more hints, clues, fragments of possibilities of other ways that we can challenge the system in any way at all?
Yeah, I mean, doing more of this and just I, you know, it does make me scratch my head a little bit of that. I get that healthcare is really complex, so some of it gets too much, I think, so people tune out. So I think just continuing to have dialogues and simplifying some of the key pieces, but you're correct right now. Like we actually now have a government that it's kind of odd that not only they seem to be driven by ideology, but then it's actually hard to figure out what their ideology is sometimes, even so, in regards to ignoring the experts. And so yeah, I mean, I guess it's just more of beating the drum, and more of, sadly, a lot of my colleagues, and I'll just say this, I hear it again and again. So there's intimidation, and they feel muzzled or afraid to speak out. But even the ones that may not, they feel right now that no one's listening, so they kind of are just like hoping that at some point access to healthcare gets so bad that people will get to a point where they'll no longer be able to ignore it, and they'll no longer be able to remain quiet. But I'm trying to be optimistic and hoping that we don't have to get to full collapse before that happens. But I just think more, continuing discussing this, having conversations, and just trying to meet in the middle around it is going to be critical, regardless of how it plays out.
Yes, thank you so much, Dr. Parks. Very informative. I'm informed on a lot of this. Chris Galloway from Transit Medicare just released a stat about a month ago that the average age of a woman or a man leaving the nursing profession is 35 years old. The retention of those that are graduating from nursing and becoming doctors, about 14% stay in the province. My sister-in-law is a doctor in Victoria. She told me that there's 21 new doctors in the Greater Victoria area. 17 are from Alberta. I'm just, why is this government proceeding this way? I mean, the integrated health system was the best in Canada. It was a model that everybody wanted to achieve and have in their own province. How do we take it back? And what does the next government do that comes into? They still have a lot of work to do to put it back to some form that's going to work for the people and for the doctors and the nurses that staff our hospitals.
Yeah, well, yeah, so much in there, but I guess I'd say a couple things. One would be those stats are real. So the burnout and so this is something. So there's a bit of again, I always speak my mind and speak frankly, but so there's a bit of a revisionist history with the government, because I spent as in the AMA presidency, and I spent probably about the first 16 months begging them to work with us and listening to some advice and input from the physicians and the healthcare workers, but one of the things they don't really believe the stats. They don't believe what's happening until the point where we get so far behind. Then they're like, oh, we're in trouble, and they're going to have to spend so much of our taxpayer dollars to catch up once they get into the hole they're going to get into. Because right now, the moral injury is one of the biggest things that's adding to the burnout of what you're talking about. Like nurses would be the best example of where we really are losing them early, because they enter the profession because they want to care and they want to help patients, and to be put in an environments day in and day out where they're working in suboptimal environments where they have really high patient loads, really complex patients, and not enough supports and staff, and then add the the frustration of families and family members and patients who are rightly frustrated but taking it out on the wrong people. And add all those things, it just becomes a vicious cycle, and it's real, like it really is. And government will often spout things like, well, we're going to pay nurses the highest, and we're going to pay doctors. Alberta doctors traditionally were the highest paid. That's slipping. But they're really ignoring the fact that money isn't everything. That if you make a lot of money in your job, but it sucks every day to go in, you're going to choose other places. And I've lived in Alberta for 25 years, so I don't want to sound like I'm, putting aspersions on Alberta. I love it, but there are nicer places to live, like the west coast of BC and things like that too, where there's draws that are different than Alberta's as well. So the only reason I mention that is it's not just money, and our government doesn't seem to want to believe that. So trying to get those kind of facts out there, trying to make people understand, and then again, just really trying to make it about the patients and making them understand that when their loved one gets admitted to a floor now regularly, where there would be, say, 30 patients on the floor, there's 39. And where there would be 10 nurses to care for that, say, there are 7. So the care that they'll see their loved ones, sometimes if they can't care for themselves and bath or do their toileting, they'll sit for hours in their own, feces, things like this. They'll see what's happening. And this isn't because the nurses don't care. They care. They just are so overworked and understaffed. So I just, again, I would reiterate, I hope we don't have to get to where it's so bad that finally, everybody gets mobilized. I'm hoping we can get there before that, because then the other side, why people should care, is it will cost a lot of money to dig us out of the hole that we get into with workforce and with our structure, and that's our money. We're paying a lot of money to government to be fiscally conservative. If you're someone that votes for that party, again, if you are, you can see that this is not fiscally conservative policy.
Yeah, I had a question about the local decision making. To me, that just seems like privatization, where, like in the American system, each company would own a hospital and all their decision making. That you had said that it's not a bad thing for local decision making, that healthcare workers have been asking for that. Is it, like, what's the appeal to that?
I should clarify. So I think we're talking two different things, and it's good you highlighted that, because as healthcare workers, what we would say and what the premier has heard, and it'd be fair from people working in, say I'm in Medicine Hat. An example would be Medicine Hat's not the same as Edmonton. It's not the same as Calgary, and we have some unique programs where we could be like, listen, we could do A, B, and C way better and efficiently for this type of patient, and we want to be able to create our own program and get that going quickly. Well, in a big org that has to go somewhere and it doesn't always come back quickly, and that feels like we don't have control of our own environment, and sometimes it's true that we don't. So could don't throw the baby out with the bathwater. Could we have kept what's good about our integrated system and improved that? Yes. But now what you are talking about, and that's why we have to be careful around semantics, and because I do think that's what the premier is talking about when she's talking about local decision making and things, is like having hospitals have full control of their budgets and be, compete with other hospitals, and that's a different thing than being able to. It's different than being able to get shit done in your hospital versus competing. And I'll give you an example right now. The government doesn't have a clue that if they went to this model right now in Alberta, I'll do the South Zone or North Zone. Let's talk about North Zone. Edmonton takes in, 15,000 patients a year or more, 20,000, somewhere in there, from out of zone into Edmonton, because they're more complex. They need specialists. They need, you name it. As soon as you create this competitive market where you have, say, U of A only wants to look after its own little area, and Royal Alex, and you'll lose that immediately. And it'd be the same as in Medicine Hat, or say you're in Crow's Nest Pass and you want to get someone to Calgary, but they've got their budget and their local control, and they don't care about your problems out in the regional or rural. They have no idea about that map and that plan. So thanks for the question, because I think the key piece is that healthcare workers have been a bit frustrated that the command and control of a big organization has some delays, and you're not able to get stuff done quickly in your local center. But that's a bit different than what the premier is announcing and what she's envisioning. And we have to be careful, because one is probably a good thing, that we can have a bit more fluidity and being able to react quicker and be able to be unique in your decision making in different areas versus competitive, full budget, local kind of control that the premier is proposing.
Do you know if the government is building any more continuing care or long-term care spaces?
I'm not aware, because that's part of the problem now. Is it's hard with the four orgs now. It's really hard to get the data now. And then again, what's happening now, and that's a good example of where, because there's so many different types of orgs and how for profit, private ones, and nonprofits, and ones that AHS used to have that no longer have. It's clear as mud. And so and a key piece that is really important, and I've said this a lot too, is that a bed's just a bed if you don't have anyone to staff it. And one of the biggest things we have to understand about continuing care is that, especially when you have the for-profit component to it, the way to make more profit is to have less staff and less supports and less care delivered in those places. And so we need to be really eyes on not only what are they building, but what are they doing to staff and our workforce. And so my long answer to your question is no. We don't have a clue. I don't know what they're doing around continuing care. And again, that's why I gave you this idea around the command and control and operational control. To do my job in the emergency department, I need to make I hoping and praying someone is taking care of continuing care, because that's the thing that will help our hospital flow and help our emergency departments. And I have no locus of control over that. I have no ability to influence it other than in the big picture. So and that's why this siloed system is really dangerous and broken.
The problems you're talking about go back a lot further than your 25 years. Tried the same trick you did of getting to be president so I could fix things, and found out they wouldn't talk to me. But to look at local control, when I arrived, we had local control, and it meant that we had one administrator and one accounting type that we don't have in the hospital now. And we had a hard time finding the right people. If we have to create more than 100 of those, places like Fox Creek probably don't even have the skill set needed. How are we going to staff not just the anesthetists and the nurses and so on, but the administrative staff? This is going to blow up the bureaucracy in a big way. And we will probably go back to the no rapid to take care of the referral problem.
Rapid would disappear again. Why would any hospital take on the problems of another region and another hospital when they're trying to work with their own budget, right? And that's probably a bit of an exaggeration, because physicians care and they would try to take care of the sick ones. But at some point, the administration and the bean counters probably don't care. It's all numbers to them, and it becomes all about budget, and it won't work. And there's no consultants that are telling the premier that this is a good idea. There's no healthcare workers that are experts, and there's no plan. I've been begging everybody, every single consultant firm, every single healthcare leader to show me what's the roadmap for what the premier is just making announcements, and then everybody's scrambling and trying to fit the square pegs in the round holes of the salad they've created.
Hi, Dr. Parks. It's exciting to meet you because I've heard so much about you, and I think you've done so much for us here in Alberta. If we could just clone you and have you in every area of our province, I think that would be the best thing for us. The thing that I'm going to talk about real quick or ask about real quick is because of how she's doing this and the way she's doing it, I'm finding that even though healthcare is like an entire province-wide problem, everybody has to deal with what goes on with this healthcare some way or other, either a family member themselves or whatever. But it just seems to me like everybody thinks that she's going to solve this thing like a miracle and it's all going to be wonderful, with this resegment of everything, instead of like I was thinking like what you were saying, which that's what came to mind first of all, is that when you've spent $2 billion building a system, you don't throw it out with the bathwater. you look at how you can restructure it, where you can cut, areas that are just redundant, or money's being spent in positions that you don't need, that you can you can basically streamline things that way and cut your red tape so that there's less layers of people to go through to make things happen. And but the thing is for me is that I'm a cancer patient. I just got diagnosed. Oh, I can't do this. Metastatic breast cancer in my bones. So the cancer clinic to me is also a very critical part of the system that is being harmed a lot. When we get our funding from the federal government, I don't know if you can even answer this question. Do they just hand it over to the province? Do they take it and just do what they want with it? Or should they be expected to somehow or other show where they're spending their funding? Like, they can't be using it all for the healthcare system. I don't believe they are, because of the way things are right now. Like the two hospitals that we have, Royal Alec and U of A, one was built in the 1800s, late 1800s. The other one was the early 1900s, and they're old and antiquated, and they're, like the equipment probably hasn't been updated for many years. And the same for the cancer clinic here. I talked to a physician there when I went through their pain and symptom clinic, and she advised me they're putting almost 500 patients a day through that clinic, and they don't have even close to the right amount of oncologists. They need at least, I think, 30 oncologists to operate it efficiently and properly. And for this reason, a lot of people's cancer is getting away from them, and they're losing their lives over it. And since the 90s, when Ralph Klein did do his initial cuts and whatever he did to the healthcare system, same thing there that Kenny did. The hospitals have struggled for years with their capacity issues, and the ERs went from like 3-hour waits to 6, and now to 12. So I mean, it's all part and parcel. That the most important thing to me would be looking at capacity, building new hospitals or some long-term care facilities to try and help us get this system under control. I don't think we needed to touch what she's doing right now, and I don't think it's very good. I think it's going to cost lives. If I wanted to try and do something about it, what would you recommend? Because I don't want any more people to die needlessly because of her and what she's doing. I really want to find a way to do something to help fix what's going on. So I would like to figure out what's the best way to try and get to people, because they don't want to listen. They just believe all the bullshit that she's spewing, and she's not. She's not being truthful, and she doesn't seem to have a heart. So what would you recommend would be one of the best things to do to try and make people believe us and actually come out and help fight for our rights and for our lives?
Yeah, well, I'd say do what you're doing and keep being brave, Denise. Like, I think it's very brave to share what you shared and to share your experience. And I'm sorry about your diagnosis. And in fact, that's partly, I think, why a lot of us are here, is that we know we could do way better. Our system could be way better. And um, there's a couple of things. Your story and your experience highlights a lot of things of what I see every day, and it is. I think the two things that I would strongly say, one is tell your story and your experience, because one of the things we've learned, and I've learned more and more now, is that to the government, you're just a statistic. You're just one of however many people with cancer, and it should never be like that. Everybody should be knowing that patients in the healthcare system are someone's loved one, and or us, and so telling stories and making people understand what the impacts are is going to be one big crucial piece of it. And that's a piece that's been missing in my advocacy that I've been trying to do as well, is that the stories like yours are not mine to tell, and then we have confidentiality, and we know about all the stories, and we hear so many heartbreaking, difficult journeys that people have, and I wish we could share them. And so part of it is starting to try to socialize more people telling their stories, because that will help. It makes a huge difference. And then everything you just said about cancer care is 100% true. And I think one of the things that you personally can do as part of telling your story is demand transparency around important metrics of you'll see our government doesn't post or talk about cancer wait times. They got rid of them. We used to have them posted because they got bad. They got worse and worse. I spent a year directly talking to the government about our oncology shortage and begging them to they wouldn't believe us, and they wouldn't believe that it was bad, and to the point where they were removing their own data around wait times because it was getting so bad. So I think we have to get to a point now where we can demand of our government that they really show concrete, transparent data about. Right now, they're playing a game of the only surgical wait times they're showing are the quick and easy surgical wait times for joints and eyeballs. And they're
Yes.
not putting things like cancer waits and cancer surgeries, and they're not putting, time to see an oncologist for chemotherapy or radiation, like all these things that should be standard. So I can just say thank you for sharing. This is difficult and it's hard and it's emotional, but we need more. I think every Albertan has loved ones like yourself that's going through this and having challenges or go through it personally. And I think we have to normalize sharing it a bit more, and so people know that these aren't just statistics, that these are real human people, human beings that are going through this. So don't keep telling your story.
Thanks, Ali. Thanks, Dr. Parks, for being here. Heartbreaking stories on many different files. This government is just corrupt and evil. It simply has to be replaced. Support Ali, Alberta Resistance. Dr. Parks, we went through COVID. We went through triage. It was nearing the point where the system was collapsing. Triage was occurring. Now we have the measles outbreak. Can you comment on just the misinformation and the just the lack of science and the movement of Take Back Alberta, the UCP, to discredit medical science? And this is where we're at right now with measles. It's only going to get worse. Do you see triage based on vaccination becoming an issue at some point? I mean, where are we headed, and what are the warning signs here?
The misinformation is massive. I'll tell you, I lived through, we all lived through COVID. I was on the front lines and lived through almost having to pull the triggers on the triage protocols, and how everyone has their scars from that. And it was very difficult. And now to see our government come out and embrace and actively court and really support contrarian slash wrong and misinformation, and elevate it to a level of discourse where it shouldn't be, is very, very difficult. And I think we have to have I think we like, being very blunt, the government owns this measles outbreak 100%. Everything this premier did and everything this government did has caused this outbreak. So by quieting the public health officers, of explaining to people who might have been able to be persuaded to have vaccines, by not acting on some of the information and data we had coming, by spreading active misinformation around vaccines, by actively discrediting experts and physicians, a lot of things, so many things that I think we have to start to say, listen, you know what? There's two pieces to it. One, I believe the government created the situation we're in. And two, why should everybody care about it? Is even if you don't get measles, it means now when you come into my medicine at Emerge, you might wait 6 hours longer because we can't use the rooms because we have patients with measles in them. And you can't get admitted to the floors because we have isolation because of measles seclusion. And so you might come in with your chest pain and your heart attack and might have very suboptimal outcomes because we're dealing with a highly preventable disease. because our government let it run rampant. And everybody has to understand that it's not a zero-sum game, that if we spend millions of dollars now to contain measles and to treat measles, that's millions of dollars we don't have to treat cancer care or pediatric conditions, or you name it. So it is really going in the wrong direction. It really is. And what's sad now, what's adding to the burnout, and I'll just be blunt about this as well, the nurses take it the hardest, and you have these people who have been misinformed and bought into really bad information that make poor decisions, and then come into the emerged departments or to healthcare workers, and then still don't want to believe us and take our advice. And it gets into a very difficult position of where, why are you seeking our advice if you're not going to value it or listen to it in any way? And that is escalating as well, and it's creating increased violence in our facilities, and it's increasing burnout, and it's adding to a question I had earlier. Why might people go to BC? Why might they go to Saskatchewan or Ontario or the Maritimes, and get paid a little bit less? Is because they might be working in an environment where expertise and their opinion and their skill set and their years and years of training is valued. And lots of times it doesn't feel that way in Alberta, and we have to break that cycle. So again, I keep giving you guys long answers because everything's complex, but I'll say that you guys, everybody here and everybody saying, you know what, we're having an insane half-century outbreak of measles because of everything our government did, and we have to put the ownership where it lies, and we actually have to remember that when we're listening and or next times we vote. So
I have two questions, very quick questions. First is the organization that the UCP is heading towards. If we replace the government today, is it recoverable to bring it back to the integrated system?
I have to be optimistic and say yes. You know what? I think there are some people. Yes. It will take an operational control and an oversight. If you really want me to tell you, what's the saddest thing is the government created 4 pillars, right? They created continuing care, primary care, acute care, and recovery. They didn't name what the pillars are sort of supporting up. They didn't create the actual command and control and the whole system. Because why didn't they do that? Because that would be AHS 2.0 and bigger than AHS. And so for political ideology, they created 4 standalone pillars that aren't holding up anything. So yes, some smart people could salvage some of the pieces. Will it cost money, and will it take some time because of some of the damage done? Yes, but yes, we can. And but what it will take is not government meddling and saying, here's our ideology, fit this square peg in the round hole. It would be like, okay, let's go to some experts that know what they're doing, give it a 4-year plan, and stay out of it and let them fix the system. But yes, I have to believe we can fix it. We're not at the point of no return now. I do think if we carried on with this for 6 to 8 more years, absolutely, things would just have to collapse before we could be able to fix it.
And is there any place for reaching out to the federal government to help control this situation in the province?
So that's a talk all on its own. And yes, so one of the things that I'll say, and maybe it's a good place to end, is that our federal government's abdicated their responsibility and to a degree, and it's toxic to get involved in healthcare as a Fed, because for the longest there's lots of dynamics. The provinces want the money and want to do what they want, and they want to control healthcare. I think, and I got asked this question earlier, do they, like, for example, when they're transferred cancer money or they're transferred funding for healthcare in general, the question was, does government have to spend it on healthcare? No, they can build roads with it. They can build pipelines. They can build, go up and use it to invest in our oil and energy industry. They don't have to use it to healthcare. So the quick answer to this is, I think what we need, one of the pieces we need, is to have our federal government say, here are big chunks of money that are going to healthcare. And what we are tying this to is, for example, I'm just making up an example. Maybe it's that every single Canadian has access to a primary care provider. And this huge chunk of money has to be used over the next 5 to 10 years for that, with receipts. You have to show we spent it on this. These are the results we got. it would take a lot of, courage for a federal government to do it. But it would be certain provinces would embrace it. And I'm betting you guys can guess which provinces would actively resist that. But I think it's within the mandate of the feds to be able to do it. And I do think that if we don't do that in some way where we say, listen, these are healthcare dollars that we believe as a nation needs to go to these key core principles of healthcare, and we support this as a nation, and this is what we're funneling it to, and here you can figure out your own creative way to have everybody have a primary care provider as an example. We're not dictating to you how you have to spend it. We're just saying this is the pot of money for that. You be creative and figure it out, and then have benchmarks, and then say, how did BC do? How did Nova Scotia do? How did Alberta do? What worked? What didn't? I think the feds could help us huge on that, and maybe we're getting close to an appetite for that because every province is struggling with healthcare in similar ways, and that might be something we could urge the feds to start to think about, and as a nation we have to think about, because I really worry that as a nation, if we let it go further and longer the way it's going, many will just abandon publicly funded healthcare. And I think as a nation, we should not do that. I have very strong beliefs about how that'll really impact our people without the ability to pay. And so if we're going to say and recommit to the Canada Health Act, and then maybe we can say it's time to look at what kind of strings we add to that funding. No one's really talking about this, and it's unique, but I do think it's something that could be a whole hour-long talk all by itself. But it's something to think about.
Where are we with doctors here? Are we on the edge? And has the AMA ever contemplated a class action suit on moral injury, given that you are being actively prevented from doing the job that you are trained to do and want to do?
Part of it, I think that I'll tell you that's very difficult for the AMA, and this is again my own perspective and just giving my own is AMA is in this very unique position of trying hard to work with the government, and trying to convince them to listen to the AMA and listen to the input, with at the same time, seeing that we've been stymied and having difficulty with progress, and so doing something like that from an AMA perspective would probably immediately take off the table any kind of collaborative input and or interaction. So that's a tough one. But on the other side, I think one thing we're going to need help with so Athana's case is a perfect example. She's not a healthcare worker necessarily, but she's a perfect example right now of where we do need some type of whistleblower / protection where our healthcare providers can raise some of these concerns, and put them forward maybe in a class action suit, or put them forward in a protected vehicle that allows them to show, for example, the moral injury that's happening, and show the positions they're put in where they can't advocate and are muzzled. So and it's missing. We don't have in Alberta. The Health Quality Council of Alberta, now called the Health Council Quality Alberta, I guess, but they used to have a mandate. It got taken away. We don't have any vehicle for that. So, and right now, that's why there are a lot of physicians that feel and talk like I do, and they talk to me about it, but they won't come out publicly because there's no vehicle to be able to do it in a protected manner. And so it's just a tough question, but it's something that I think if we were to argue for transparency and protection of our healthcare workers, that would go a long way to getting at the truth of what's going on.
Well, thank you so very much, Dr. Parks. This has been really difficult and really important, and we have the information now. This video will be available for everybody to review within a week or two on AB resistance. And if you really want to help and do something, I suggest that you contact ABR and perhaps become a member, because we are actively working on a number of different strains of ways of fighting back and educating people. So do check out the website, although it's currently in a new stage, so it's limited right now. Thank you so much, Dr. Parks. One last question came in was that can you recommend any sources of information where we could find out more?
So, I think part of it is having a bit more dialogues like this, but part of it, if you have a primary care provider, if you have people you trust, take a minute or two and ask them and see as well. But we're trying hard to push the government to get things like transparent data and a lot of patient-oriented metrics, but they're just not biting and they're not interested. So there aren't a lot of sources right now that are easy to turn to for patients or for advocates.
One more personal question, Dr. Parks. You, amongst very few who started out protesting and speaking out, and those numbers have dwindled as the years have passed. How are you doing?
It's a bit of a funny environment because every single time I open my mouth, colleagues call me and say, "What are you doing, Parks? They're gonna come after you." But I just think my strategy now is to just be as frank and candid and be truthful. And I mean, it is a tough environment now. Like I could never get a position in Alberta Health Services or Alberta Health or anything in a leadership in Alberta right now with this government because they are not happy with me. But I just think it's important. I think that having the opportunity to try to continue to make an impact does rejuvenate me a little bit. It would be nice if we could make some progress, but I think actually, you know what, and two things kind of give me a bit of energy. One is hearing from, patients like Denise and others that have had lots of trouble and hearing their stories and trying to fight on their behalf to make the system better. And the second is a lot of my colleagues do reach out to me and tell me their troubles or their difficulties or their experiences and frustrations, and so they can be a conduit through me right now, and so I'm trying to do that a little bit as well. So thanks for asking, but it can feel a little lonely screaming in the hurricane here a little bit, but I appreciate groups like yourselves that are trying to add their voices and trying to just get out real information and make people informed.
Thank you so much. You have made a huge impact and it will radiate out there in the coming days and weeks for sure. So I'd love to have you back again. We'll format about what you want to say, what you need to get out there, and maybe some brainstorming about what average people like myself and people who are attending today can actually do. Because I'm a firm believer that education is liberty and education is also responsibility. And so we are armed with more information, far more than we had before tonight. And I thank you so much for that. And thank you all who attended. This is really important, and we keep going because people like you are concerned. So our next step is we're concerned now. How do we make that into action? So thank you all. Good night. And please join ABR if you want to help out. Thank you so much. Good night to all.